Hello, and welcome to Huntington's Disease and Physical Therapy, a free CEU course for community-based physical therapists who are not familiar with Huntington's disease. This 5-part course is brought to you by the Huntington's Disease Society of America in cooperation with the American Physical Therapy Association. To earn a CEU, you must answer 75% of the post-test questions correctly and complete the form for a certificate of attendance, which will be issued by HDSA. Module 2, Physical Therapy Evaluation of Individuals with HD across disease stages, will be presented by Drs. Ann Kluth and Deb Kegelmeyer, who are co-investigators in the Ohio State University Mobility and Exercise in Neurodegenerative Disorders Research Lab, where they investigate physical therapy interventions to treat balance and mobility problems in individuals with Parkinson's and Huntington's diseases. Dr. Kluth received her physical therapy training at the University of Wisconsin and her doctorate from Cleveland State University. She's a neurologic certified specialist and has over 25 years of clinical experience, many of which have been spent working with patients with neurodegenerative diseases. She's a professor of health and rehabilitative sciences at The Ohio State University. Dr. Kegelmeyer received her physical therapy training at The Ohio State University and her Doctor of Physical Therapy from MGH Institute of Health Professions. Deb is a geriatric certified specialist. She spent 12 years working as a director of rehab services at a skilled nursing facility and has been on faculty at OSU since 1995, where she is an associate professor of health and rehabilitative services. A handout of today's slides can be accessed by going to your control panel and clicking in the section labeled Handouts. You'll be able to download them during or after the presentation. Before I turn this presentation over to Ann and Deb, I'd like to take a moment to go over how to ask a question. Questions will be answered after the presentation, but you can send a question at any time during the presentation. To send a question, go to your control panel again, and what appears on the right side of your screen will be a small box in which you can type in your question or questions. After that, click on the send button, and we'll answer all questions at the end. And now I'll turn it over to Deb and Ann.
Hello, this is Ann Kluth, and I'm here with Deb, and we're going to be talking today about physical therapy evaluation of individuals with Huntington's disease across the disease stages. I need to explain that we have no disclosures. Here are our objectives. We would like for you to be able, at the end of this presentation, to discuss the following about Huntington's disease: common impairment, activity limitations, and participation restrictions across the disease stages. And we'd also like you to be able to discuss evidence-based assessments for use by physical therapists to evaluate people with Huntington's. I'm first going to talk about motor impairments, and those can be divided between those which are involuntary versus the ones that are voluntary. I'll talk about involuntary impairments first because they are some of the most prominent symptoms of Huntington's. Chorea is the symptom that helps a lot with the diagnosis of the disease, and it is derived from the Greek word dance, which describes the brief kinds of muscle contractions that appear dance-like because they seem to flow from one muscle to the next. Chorea initially affects the hands and feet, but as the disease progresses, it'll affect the face, the head, the trunk, and it also can then cause flailing of their extremities. It gives the person an appearance of being drunk, and they're often picked up sometimes by the police because they appear to be drunk due to the ataxic and dancing quality of their gait. The chorea usually is present in people during the waking hours, and generally they're not able to suppress it voluntarily. It also often will worsen if the person is very anxious, such as when they're coming in for a physical therapy appointment or a doctor's appointment. And it also is usually less when the person is sleeping. Dystonia is another common involuntary motor impairment, which is those sustained type of muscular contractions that could result in an abnormal posture or torsion type movements. Common dystonias that are seen in people with Huntington's are arm elevation while they're walking. Sometimes they're tilting of the trunk. That could be side to side, or it could be in extension sometimes. Internal shoulder rotation, sustained fist clenching, excessive knee flexion, which you see sometimes during gait, and also the foot sometimes will tend to go into plantar flexion and inversion. Tics, myoclonus, and tremors are less common involuntary motor impairments, but they are typically seen more often in children and young adults with Huntington's. I'll now talk about voluntary motor impairments. Bradykinesia, or slowness of movement, is very common, and this can be seen very early in slow initiation and velocity of those fast saccadic eye movements. It's also observed with difficulties with rapid alternating movements, such as finger tapping or foot tapping, and difficulties with movement sequences. So it may take longer for the person to, say, switch from one movement to the next movement in a sequence of movements. Decreased coordination is another voluntary motor impairment that really can affect the person's fingers and manual dexterity. And this in turn then could affect their ability to do fine motor skills like writing, getting themselves dressed, or cutting food. In later stages, the decreased coordination in the extremities can actually lead to problems with driving. Other motor impairments are impaired force modulation control. This can be seen in that sometimes people with Huntington's will have exaggerated movements, and sometimes it can cause them to actually lose their balance because they reach outside of their base of support, or they might be just trying to get up out of their chair or bed, and they instead just vault forward and end up landing on the floor. Another motor impairment is impaired eccentric motor control. And this also can lead to falls because people with Huntington's might have difficulty, say, controlling themselves when they sit down, and they'll end up plopping into the chair, or when they're trying to go downstairs. Motor impersistence is a motor impairment that you commonly see in people with Huntington's, and this is just an inability to maintain a voluntary muscle contraction at a constant level. So the way that this manifests is that often a person with Huntington's will drop objects. For instance, they're holding a glass, and maybe they're not thinking about it, they're distracted, and they'll just suddenly drop the glass and it'll break. It also could lead to incomplete chewing of their food, and in terms of driving, it could actually cause them to have very inconsistent driving speeds. The motor impersistence is independent of chorea, but it is linearly progressive, so it will get worse as the disease progresses. And in terms of physical therapy, it might prevent the person from being able to effectively use a walker. So I'm going to talk about the changes that occur in chorea and voluntary movement with disease progression. So for chorea, initially it's going to worsen, but at some point, usually in the middle stages of the disease, it'll plateau. And then in later stages, it actually will decrease sometimes because of the emergence of Parkinsonian symptoms. And these are caused by increased amounts of bradykinesia and rigidity. However, voluntary movement deficits will continue to increase throughout the different stages of the disease. So although chorea is very useful in terms of the diagnosis of the disease, it is a very poor indicator of disease severity. And typically, it's important to know that it doesn't usually interfere with functional task performance, except when the chorea is severe. It's the voluntary movement deficits that are responsible for a lot of their functional problems. Muscle strength is initially not a problem for most people with Huntington's, but it will decrease as the disease progresses. And it's really not known if muscle weakness in Huntington's is a primary impairment of the disease, or could it be secondary to the fact that they're very inactive and they may have disuse atrophy of muscles. There is some evidence in symptomatic individuals with Huntington's and also asymptomatic mutation carriers that there is delayed recovery of ATP levels in their muscles after exercise, which is due to mitochondrial dysfunction, and it's thought that that might contribute to some of their muscle weakness. Muscle tightness and poor posture can develop in people with Huntington's. It could be because of postural habits they have, dystonia or immobility. There's a tendency for people to adopt a very slouched position with excessive thoracic kyphosis and a posterior pelvic tilt. In later stages, the person might assume a very masked type of flexion posture. Tone is generally increased, so deep tendon reflexes can be hyperactive, and later stages, as I mentioned, they might have rigidity, and they can actually become very akinetic. They also can exhibit what are called hung-up reflexes, and this is where after the muscle tendon is tapped and you get the motor response, it takes longer for them to go back to the neutral position. As motor impairments increase, and especially during the middle stages of the disease, you see a lot of balance and gait impairments that can really increase fall risk. Some of the typical gait impairments are slower speed due to that bradykinesia, shorter and also more variable step and stride lengths. They often have a widened base of support and increased double support time, probably because of balance problems. And they exhibit trunk sway, both anterior, posterior, and medial lateral, and path deviation. In terms of balance impairments, studies have shown that people with Huntington's have more sway when they're standing quietly and during daily activities. If they're perturbed and lose their balance, they have slowed recovery responses, which could lead to falls. There's also difficulty with standing with their eyes closed, standing in tandem or walking in tandem, and single leg stance is very difficult for many people. I'm showing here just an example of some of the walking patterns you might see in a person with Huntington's. In the top graph you see, these are from a gait right system where you have a carpet on the floor, the person walks over and the sensors will record their footsteps. So on the top you see a figure showing normal walking patterns, and you can see the person's steps are pretty much equal and there's no path deviation. But below is a typical Huntington's walking pattern, and it just shows you how variable the step lengths can be, and as well you can see the person has some path deviation. They've studied falls in people with Huntington's, and they occur most often in the middle stages and usually in a person's home. And there's several kinds of activities that can really provoke falls. One is multitasking, so there is a decreased ability for some people with Huntington's to do two things or multiple things at once. Climbing stairs is also where a lot of people fall, and it can be both going up the stairs, they might trip on the steps, or going down stairs for multiple reasons. Turning quickly, especially when a person has something in their arms like carrying a load of laundry, that could cause the person to fall. And stepping over obstacles on the floor is a big problem. Another reason that you commonly overlook that you really should think about is that just wearing unsupportive footwear like high heels, sandals, flip-flops that don't really support their foot, that is something that can also contribute to falling. Other motor impairments that you see in Huntington's are dysarthria and dysphagia. So typically people with Huntington's will develop a slurred kind of speech. Their speech rate may be slower, and they might have more speech pauses, and sometimes the quality of their voice is affected. They may have some hoarseness or breathiness, or the amplitude could be either too low or it might and sometimes be too high. Swallowing problems occur in all phases of ingestion. So they have problems bringing the food up to their mouth, actually chewing the food, forming the bolus, and then swallowing while they're also trying to inhibit their breathing. That coordination sometimes is not working properly. And a combination of things can lead to choking. It could be inadequate chewing of food, so they're not getting their food chewed up properly. Rapid and impulsive food consumption is another problem, as well as the poor coordination of the muscles for swallowing. And the choking then can lead to aspiration, and sometimes people will get aspiration pneumonia. Along with the motor impairments, people with Huntington's are also going to be having cognitive impairments. And these actually, the cognitive impairments are known to occur very early, even in pre-manifest stages. So I've listed here some of the common impairments and what some of the manifestations that you might see that could affect physical therapy are. One is impaired perception of time. So that could cause the person to be frequently late or just underestimate how long a task is going to take to complete. They also often have impaired visuospatial perception, which is a reduced awareness of their body space and the environment. And this often leads to frequent bumping into objects, which could cause injuries. There's overall a decreased speed of processing of information, and so that just means that it might take them longer for them to respond to, say, something you ask them to do or just to come up with an answer. So you need to be very patient and wait for them but they will usually be able to respond. But you also have to take in consideration that because it's slower to think and perform motor skills, it's also going to be more fatiguing for them. Short-term memory decline is seen in terms of it can affect their ability to learn new information, and they also can sometimes have trouble retrieving previously learned information. But with cueing, oftentimes they can retrieve the information. Now, in contrast, long-term memory is often pretty much spared throughout the disease. Executive function deficits also can, in multiple areas, attention, being able to plan, make decisions, that will all impede acquisition of new motor skills. And the intentional problems can really lead to that, as I was talking about, difficulty with multitasking. An interesting thing you need to know is that they've actually found in studies that people with Huntington's have a lack of awareness of their own actions and feelings sometimes. And this leads them to overestimate just how competent they are in being able to control their behavior and emotions, but also it may make them think they're better at performing activities of daily living than they actually are. So you might see this in, for instance, a person who's been falling on the stairs multiple times, and then you observe that when they get to the stairs, instead of slowing down, they're just bounding up the stairs, despite the fact that they've fallen. Eventually, cognitive symptoms will develop into full-blown dementia. I'm now going to talk about behavioral impairments, which are in addition to the motor and cognitive problems, and they also occur at very early stages. Depression is one of the most common behavioral impairments, and it could arise from the person's feelings of low self-esteem or maybe guilt because they feel like they're being a burden to their family. Along with depression, often they have anxiety. And this might be in relation to just uncertainty about when the disease is going to start, if they're in the pre-manifest stage, or just once they're symptomatic, just worrying about what's going to happen in the future. Apathy is very common, and this is something that really affects physical therapy in terms of their motivations to want to do exercise. It manifests often as just loss of energy and initiative. They might not persevere as well at tasks, so the quality of their work might decline. They often exhibit a very passive behavior where they just don't seem to appear to be concerned about doing anything. Unless they have somebody, who will kind of ask them to do a behavior. It could be impaired judgment, poor self-care, and also sometimes they appear as if they're emotionally not showing very emotions, and there's blunting. Irritability is one of the first behavioral impairments that people show. Often families will say, oh, the family member just is getting harder to get along with. And this may manifest as rude or hurtful comments to people, which can really affect family relations and escalate into serious disputes and even physical aggression in later stages. Disinhibition and impulsivity can be manifested as temper outbursts, sexual promiscuity, and acting out without thinking. We have to think about this in therapy in terms of safety for the person. Obsessions and perseveration is when a person often they just get stuck on an idea, or it could be a motor task and they just have difficulty switching to another one. And this goes along with the idea they often have difficulty if their routine in some way is changed. So they might get angry or upset if you're changing a routine that they're used to. I want to mention some other impairments that you should be aware of, and that is sleep and sensory impairments. Many people with Huntington's have impaired initiation and maintenance of sleep. They spend less time in that deep, rapid eye movement sleep, and they have reduced total sleep time compared to just healthy individuals. This can lead to them actually mixing up their days and nights where they're up all night and then they're sleeping during the day. In terms of sensory disturbances, you always want to ask people about whether they have any pain, because they often have musculoskeletal pain from a variety of reasons. It could be dystonia, muscle imbalances, just because they're not very active, and also injuries from falling or their limbs banging into things. There have been proprioceptive deficits reported in people with Huntington's, but it's really not known how those deficits affect their active movements. You also should be aware that there has been abnormalities found in cardiovascular responses to aerobic exercise. During maximal exercise testing, individuals with Huntington's were found to have reduced work capacity, lower anaerobic threshold, and an earlier increase in blood lactate compared to healthy controls. There's just in general a very high level of inactivity in people with Huntington's, and this is probably contributing to decreased cardiovascular endurance due to deconditioning. Respiratory function might also contribute to decreased endurance, and in early stages of Huntington's, people are not really they're not really complaining of any types of respiratory problems, but as the disease progresses and advances, they will have obstructive and restrictive disorders which could contribute to endurance problems. A final problem I want to talk about is weight loss, because this affects the majority of individuals with Huntington's, and they experience it throughout all stages of the disease. We don't really understand what is causing the weight loss, but there are a lot of hypotheses about possible causes. I've listed here some of the causes: dementia, depression, chewing and swallowing difficulties. They might actually have problems, orodental problems. Motor disturbances might make it difficult for them to bring food to their mouth. They could just have muscle atrophy because they're so inactive or immobile. Another thing you have to think about is if they have malnutrition because they're not getting adequate food intake, and also side effects of medications. So anyone that is showing excessive weight loss should be referred to a dietitian so that they can get some counseling about how to control their weight loss. So in summary, I just am using here the ICF model to kind of put together how do the body structure function impairments affect activity and finally participation for the individual. So you can see I have listed here, and I've been talking about a variety of body function and structure impairments. These impairments then can affect the person's ability to walk, to be able to transfer, to go up and down stairs, to communicate, and to be able to eat. And of course, they can all lead to falls, which can really decrease the person's quality of life. These activity limitations then, in turn, will affect the person's participation in their ability to do their life roles, being a spouse, taking care of their children, being able to work, and being able to do the activities they do in the community or recreational. And I want you also to see how personal factors and environmental factors then can contribute to either making activity limitations better or worse. So personal factors that you want to be thinking about are the person's age, and do they have other comorbidities that might be affecting them. Also, the level of their physical and social activity can have a big impact on these activity limitations. Environmental factors that could be facilitators or barriers to activity would be the home environment, the amount of social support they're getting, and whether or not they have access to healthcare providers that do understand the impact of Huntington's disease. And I'm now going to turn this over to Deb.
Hi everyone, this is Deb Kegelmeyer, and I'm going to talk about ways to do assessment across the ICF model, in particular at the body structure and function level and that activity functional level. So for physical therapy assessment in Huntington's disease, we need to be very aware that the client with Huntington's disease is impacted by changes in all of their body systems and in all areas of their lives. So the assessment needs to be very global. It should incorporate as many areas of the ICF as possible. Huntington's is a lifelong degenerative disorder, and because of that, we're encouraging people to start assessment early and to do it at regular intervals throughout the individual's life. In many of these neurodegenerative disorders now, the push from the neurology section and therapists in the field is that we become providers that follow this individual throughout the course of their disease. And as such, we should see them as early as possible, get a baseline assessment, see where they are, and provide advice, and then see them at regular intervals to figure out where they are and how to optimize their progression through the disease. That early and ongoing assessment allows the healthcare team to promote optimal health and wellness so that we can ensure that they do stay active. And as Anne mentioned, many times these individuals, due to apathy and all their other problems, become highly inactive, which leads to cardiorespiratory problems that can be prevented if we're being proactive early on. It also allows us to teach exercises that can delay or prevent disease complications. One that we're particularly big on is thinking about balance and trying to optimize that so that we can delay complications from balance problems. And it allows us to identify changes in the client's condition early so that we can better teach them ways to modify their activity and participation and to maintain involvement in those areas for as long as possible. We need to remember that these are often younger individuals who are at their prime of life and are still holding down a job and raising children, and we want them to be able to stay optimally active in those areas for as long as they possibly can. So key areas for assessment: are to identify the current status of the individual with Huntington's disease. Just getting a handle on all of those different motor and sensory problems that Dr. Cluse talked about. We also want to be able to monitor change over time. So I'll talk about some outcome assessments that are good for monitoring change over time and looking at the progression of the disease. It's important to monitor fall risk in this population. They do tend to have a lot of falls, and there's some unique aspects to their falling that we'll discuss. And finally, we want to be able to measure response to physical therapy interventions. So we need to know tools that will work well if we are doing a physical therapy program to measure their progress over time. Tools need to be chosen based on what the purpose of the assessment is. So different tools will work for different purposes. And often you'll have to choose multiple tools to cover all of the necessary areas. So at the body function and structure level, you will want to definitely screen strength and range of motion. You may not need to do a detailed testing unless the examination reveals a need to do that. So as we discussed earlier, impairments in this area are not always present early in the disease, but do happen over time, and depending on the person's activity level and other comorbidities may be present. It's important to note that manual muscle testing may be difficult, particularly later in the disease, and that's due to cognitive changes, so the person may not be able to follow directions for a manual muscle test, and that motor impersistence that we talked about. Individuals with motor impersistence who aren't able to hold an isometric contraction for a manual muscle test, it'd be difficult to state whether or not that inability was due to the motor impersistence or actually to a strength deficit. And that's where functional strength testing is often necessary. In order to know if the person has motor impersistence or not, you would want to assess them for motor impersistence. And the standard method of assessing for motor impersistence is to ask the client to stick their tongue out and hold it there for 10 seconds. This is an assessment from the Unified Huntington's Disease Rating Scale, or the UHDRS, which is available online. You have to do a training program if you're going to administer that full scale, but it is free and available to anyone to complete. If you're not going to do that, we'll mention some of the terms and methods that are used from that so that you communicate well with the neurologist who is doing it. In the video, you can see an individual who does not have Huntington's doing the tongue protrusion test, and we can see that they have full protrusion and are having no difficulty holding it out there. This would look very different in a client with Huntington's disease. Another method that's been utilized in the past is asking the client to close his or her eyes and hold them closed. I thought it was important for physical therapists to note that motor impersistence can definitely affect this, because if you're asking the person to close their eyes for standing balance or things like that, they may not be able to do it without a lot of cueing. This test was found not to be as valid as the tongue protrusion test. It was believed that clients would have variable performance based on how well at that time they understood the direction for eye closure. So if you're asking someone to close their eyes and keep them closed during balance testing, and you know that they have motor impersistence, you may well want to give constant cues of close your eyes to make sure that they keep them closed. It's important to look at eye movements and to do cranial nerve testing, because these are impacted by Huntington's disease. They typically start to show some signs earlier on, and they may well have a big impact on function, particularly balance and walking performance. We can use the UHDRS motor section, or we can use a chart like the one included here that allows us to assess eye movements and use documentation that's consistent with what the neurologist using the UHDRS would use. Note that this looks at ocular pursuit, or the ability of the eyes to follow an object being lifted up and down in the vertical plane or side to side in the horizontal plane. And then you would rate that as they're not able to follow at all, they have partial movement, or they have complete movement. and talked about chorea and the impact that it can have on people's everyday lives with Huntington's. It is a prominent feature of the disease, so it may be useful to measure chorea, particularly if you suspect it's interfering with function. In addition, there are now medications used to treat chorea, and it may be helpful to monitor the chorea to assist in the monitoring of the benefits of that medication for the neurologist. So chorea is commonly measured across the upper and lower extremities, the trunk, and the face, and we look at each extremity separately. You rate it on two different scales. One is it absent, intermittent, or constant? And then what is the severity of the chorea? Do they have mild chorea that does not impede function at all, moderate chorea, so small to medium-sized motions that may or may not be impeding function, or marked chorea where we see medium to large-sized motions and it impedes function? Again, you could use the UHDRS motor scale if you've done that training, or you could use this chart so that you'll be able to communicate with the neurologist in the same language that they're using. It's important to assess coordination, especially eye-hand coordination. We see problems in this area, again, with the dropping of objects or difficulty manipulating objects. We've seen in our clinic a number of clients that have a great difficulty if they work in a kitchen environment. Maybe they are working at a restaurant or areas like that. May actually not be able to work at a surprisingly earlier stage of the job because of that motor and persistence and the eye-hand coordination issues. Don't forget to assess the lower extremity, so you want to look at some coordination tests there. In the video, you can see that the person is doing the heel slide on the shin, so they're sliding up and down on both shins. This individual actually does not have a smooth movement with the left lower extremity, but they don't have Huntington's disease. They actually have a proprioceptive deficit on one side. Typically on Huntington's disease, we see fairly symmetrical bilateral coordination problems. Toe tapping can be done either in a pattern, as you see here, or you could have targets down that they're tapping towards, or you could have them tracing the shape of a circle or a square or something like that. We also recommend testing balance and including single limb stance. It's important because individuals with Huntington's disease have a lot of difficulty in situations where the base of the support is narrowed. Timing single limb stance gives you a quantifiable indication of change in balance over time, and it may be a responsive measure to physical therapy interventions for balance. We've found in our clinic that individuals with Huntington's disease have early changes in the ability to do single limb stance and that it appears to progress over time. Now I'm going to go over some outcome measures, particularly in the areas for gait and balance. There have been several studies in this area, so we now have research that we can use to back up our choices in this area. Quinn and Busey and a group of international researchers in which our lab participated looked at a number of outcome measures and checked for retest reliability, minimal detectable change, and how effective they were across the stages of the disease. All of the results are published in the Physical Therapy Journal in 2013, and you can see that reference down at the bottom of the slide. I've taken a few of those here to highlight for you. Interestingly, on the 6-minute walk test, the timed up and go, and the 10-meter walk test, participants in the late stage of Huntington's disease performed on average as well as, and sometimes better than, participants in the middle stage. Given that, it's likely that those tests may not be the best means to measure change across the course of the disease. They're still valuable, but they may not be the best way to measure clear across the course of the disease. Notice that in the chart to the right, we can see that all of these tests had excellent or good test-retest reliability, and you can see that we've reported it there in the early, the middle, and the late stages. In the article, they also compared people pre-manifest or who've not yet shown any symptoms of Huntington's disease based on the UHDRS and those who have manifest disease. Minimal detectable change scores are another area we want to be careful to consider. Those were relatively low in these measures and were consistent with findings in other neurologic populations. The important thing about minimal detectable change scores is that they give us an indication of what's the true measure of change. So you want, if you're measuring change due to a physical therapy intervention, to have the score change greater than the minimal detectable change. Otherwise, it may just be a change in score based on chance or repeated measuring, that type of thing. Typically, the MDC was higher in later stages of the disease for these clients, except for in the 10-meter walk test, it was highest in the middle stage. We can see here the Berg balance scale, the minimal detectable change was 4 to 5 points, which is consistent with other disorders. The Tinetti mobility test, it was 2 points and 3 points in the middle stage, and then up to 5 in the late stage. Timed up and go was 3 seconds, which is good. And gait speed velocity was 0.2 meters per second early, 0.5 in middle, and 0.3 in the late stage. And then the 6-minute walk test varied from 56 meters up to 126 meters. In a study in our lab, we looked at the reliability and the minimal detectable change and concurrent validity of spatiotemporal gait measures, the Tinetti mobility test, the 4-square step test, and the activity-specific balance confidence scale, or the ABC scale. And we checked that in individuals with Huntington's disease, and we were looking across a 6-week period. And you can see in the image on the right the 4-square step test. In case you're not familiar with that, you lay canes out on the floor, and the individual steps in the boxes in a pattern. Spatiotemporal gait measures, the Tinetti mobility test, and the 4-square step test showed good to excellent test-retest reliability. It was not as good in the ABC scale. Also of note, you can see that forward velocity values, the minimal detectable change was 0.3 meters per second, and in backward walking velocity, the minimal detectable change was 0.17 meters per second. Note that that's lower. We've found in our lab and several other labs that are looking at it in Parkinson's disease and the elderly that backward walking may be a good test. It may be sensitive to change early on and to change over time, and maybe possibly more so than forward walking velocity. Many other elements of spatiotemporal gait were included in the study, but you need to see the article for that. I've just taken a few of them for this chart. Again, the MDC for the Tinetti was 4 points, and it was 3 seconds for the 4-square step test. We correlated those tests with spatiotemporal gait measures like gait speed, stride length, coefficients of variability, those things, and found that the Tinetti mobility test and the 4-square step test were highly correlated with spatiotemporal measures of gait. The ABC scale did not correlate as strongly with gait measures. Of note, the 4-square step test is often difficult for individuals with Huntington's disease to perform, and that may be due to their cognitive issues, especially since they have a lot of troubles remembering and performing patterns or sequences. So it may be that the 4-square step test is best used early in the disease, may not work well in later stages. The ABC scale demonstrated lower reliability and less concurrent validity than the other measures, and we also found some individuals to have difficulty understanding that test due to their cognitive problems. Finally, it's important to do fall risk assessment. It should be done throughout the disease process. These individuals tend to have a lot of falls. They tend to have injurious falls, and we want to identify those problems and try to prevent them as much as possible. Both our lab and the BUC lab have done studies looking at tools for fall risk assessment. In the study in our lab, we did a retrospective review of 94 patient records, and we looked at the Tinetti mobility test. We found that it correlates with the UHDRS motor scores, so we know they're both measuring the same domains. We believe that the Tinetti and other physical therapy measures measure gait and balance better than the UHDRS, or at a more intense level. We found that a cutoff value of 21, the Tinetti Mobility Test had a sensitivity of 74% and a specificity of 60% to identify fallers. Those are decent values, although not excellent, but consistent with what's typically found in fall screening in neurologic populations, where sensitivity and specificity don't tend to reach the levels that they do in the elderly. Lower Tinetti scores were significant predictors of falls, and of great interest to us was the fact that younger age was correlated with an increased risk of falling. So I said that right, and you heard that right. In this study, the younger individuals were more likely to be fallers than the older individuals. And that's a very interesting finding for Huntington's disease. It may be that impulsivity and other issues like that, combined with young age, make them more likely to fall earlier in the disease. Also of note, this tends to be a younger population, and so there were likely few subjects in the true elderly age range. So in conclusion, the Tinetti Mobility Test is a valid tool for assessing balance and gait status and fall risk in individuals with Huntington's. In the Busey lab, they looked at 24 individuals with Huntington's disease, and they were assessed using the Berg Balance Scale and the Timed Up and Go test. And they found that both of those tools were valid measures and good ways to assess for fall risk. They found that Timed Up and Go scores that were greater than or equal to 14 seconds meant that the individual is at a higher risk of falls, and Berg Balance Scale scores less than or equal to 40 indicated an increased risk of falling. And now I'm going to turn us over to question and answer time.
Hi, we do have one question, and it is, how often should the patient be reassessed to monitor changes?
I think that would depend on what types of changes. If you're looking at physical therapy changes, I would be inclined to measure at least monthly to check on those. If I'm looking for changes across the course of the disease, we typically look at people every 6 months in our clinic. Sometimes as often as every 4 months. Often mid-stage, we'll end up doing it more frequently when the chorea is getting more severe and other things are having more rapid changes. But the common time frame for us to be monitoring across the disease is every 6 months.
Well, thank you very much for that really comprehensive answer. We do have a few minutes, so if anyone does have a question, please do feel free to type it in. We actually do have one. Are there early symptoms that show faster disease progression than others?
Faster progression. I know that definitely the cognitive symptoms and those behavioral symptoms are occurring like pre-manifest stages, even before like some of the motor symptoms are seen. So, and they do, for instance, like apathy. Apathy is one of the cognitive problems that does continue linearly to advance throughout the stages of the disease. So it might have, you know, a more rapid progression. Let's see.
Yeah, it's hard to say rapid progression.
Yeah, more rapid.
Earlier on, it's going to definitely be cognitive and behavioral, and we believe things like the single limb stance on a motor are some of the things you're going to pick up on earliest.
Mm-hmm.
We note deficits in stair climbing on the functional pretty early on. What I would say is if you want to have some excitement, go ahead and take a person with Huntington's disease in the stairwell and see how they do. It's been quite eye-opening to us. And they often go fast, so timing them, we think, is not the best way to measure that.
Okay. Hi, we do have another question, And is there a quality of life questionnaire for HD similar to the PDQ-39?
No, there is not.
No, the UHDRS includes some items that kind of get at those elements. So there's the motor scale, which I referred to primarily, but there are questionnaires that go along with the UHDRS that look at ADLs and participation and some quality of life.
Okay. We do have another question. Can we improve the sensitivity of fall risk by combining multiple measures? For example, would using the Berg and Tug score be more sensitive than each test alone?
Not necessarily. And we haven't looked at that. I do know that Monica Busey and Lori Quinn are taking the items from all of the outcome measures from our larger study and doing an item-by-item analysis to see if they can heighten sensitivity of those measures by perhaps selecting the best items from each measure.
We do have another question. Is there a way to stage HD patients like you can PD patients, like with H and Y scale?
Yes, there's a staging that's called the
Total Functional Capacity Scale. And we talked about that in our first presentation, Module 1, and that is commonly used to stage individuals with Huntington's. And it is really very much based on participation level functioning, like capacity to, take care of themselves, doing finances, ADLs, things that they have to do on a daily life basis. And it's divided into 5 stages.
We do have another question. Are you involved in a multidisciplinary HD clinic? Are there specific outcomes you do early on in the disease or during that clinic?
We are involved in a multidisciplinary clinic. Anna and myself are in there, physical therapy, neurology, we have a genetic counselor, we have a social worker, and we have occupational therapy and speech therapy right now. We previously also had a dietitian involved and really would love to have one again. It has been and goes beyond the scope of this call to talk about how to pull that off and how we actually pull it off. We do cognitive testing yearly. We do a standard PT screen that we've come up with that includes the Tinetti and single limb stance and some other measures that we use across the disease. And I don't know what occupational therapy is using, if she's actually using a screening tool, or occupational therapy and speech therapy are on a little bit of a different way of being in the clinic and are pulled in more on an as-needed basis. So I'm not sure how they're screening, starting early and moving on. Anything to add? There's set cognitive measures that we use for Huntington's disease. So we use those UHDRS cognitive measures.
Okay, we do want to remind everyone, while you have a few minutes left to type in a question, that if you want to download the handout, you must do it before the webinar ends. So go to your control panel and look for the handouts and click on that and download them. Okay. All right, well, we don't appear to have any more questions, and we'll leave it open for a few seconds, but I do want to thank everyone for attending Module 2, Physical Therapy Evaluation of Individuals with HD Across Disease Stages. As you can see on the screen, we have the link available for you to go to the post-test assessment. You can click on that and take the test. You must score at least 75% in order to obtain the certificate. If you have any questions, contact me. Our next webinar on the subject will be April 12th at noon Eastern Standard Time. It'll be on physical therapy management of individuals in early to middle stage HD. To register for this module, you go to the link shown here and click on that link. And if you missed Module 1, an overview of HD, which Deb and Ann did for us in December, you can access the recorded version and post-test by going to the link shown below. All of these links will be sent to you in an email that will follow the presentation today. So if you're frantically trying to write down these links, we will be sending them out to you. I'd like to thank our presenters very much for both this session and for Module 1. You guys did a terrific job, and we thank you so much for the preparation that went into each of these. Have a good day.